Like he worked for 3 years with this string galvanometer to record a ECG. Like interpreting clinically will be very easy. So he worked on this, and this is the string galvanometer that was used by Einthoven. Here the string, this is the string in between the electromagnetic fields. So this string vibrates whenever electric current passes through this. So whenever the electric activity of the heart passes through the string, it vibrates. So this vibration, when the light is passed through this vibration, it is an image over this photographic paper. So he was able to record the electrical activity of the heart through this paper. Then the evolution of electrocardiogram. This one shows the capillary electrometer, the recording of the capillary electrometer, like corrected curve. They used to develop after recording the curve of the ECG. Then this is the actual one which was recorded by Einthoven. So this was the older machines, like electrodes, which are like solutions. They have to place the both hands and then leg, and this is the electrocardiography machine which records. So these are new machines now available. So now coming on to cardiac action potential. So the cardiac action potential, it originates from. So the cardiac action potential, it originates from the SA node, then it goes to the AV node, then to the Purkinje cells, then it depolarizes the ventricular myocardium. Hello, excuse me. Hello, can you hear me? Hello.
Yes, now
Hello, sir.
we can hear you.
हाँ सर.
बीच में थोड़ा प्रॉब्लम कुछ हुआ क्या?
सर आवाज नहीं आ रही थी, अब ठीक आ रही है. सतीश आ रही है, ठीक आ रही है.
अच्छा. Okay. So let me continue. Okay, thank you. So now the surface manifestation of the depolarization and repolarization waves, that is the P wave, which denotes the atrial depolarization, QRS, which denotes the QRS. This is the QRS, like this is the QRS wave, which denotes the ventricular muscle depolarization, and T wave, this is the T wave, it denotes the ventricular repolarization. The PR interval, it is the conduction time from atrium to the ventricle. QRS duration, it is the time required for all the ventricular cells to be activated. The QT interval tells about the duration of ventricular action potential. So I'll be describing about all this later. So I am just giving an idea. Okay. So then the cardiac action potential, it has 4 phases. Phase 0, this is the phase 0. Here, opening of the sodium channel will cause depolarization. Then the phase 1, the sodium channels will close and the potassium channels will start to open. So the closing of sodium channel causes the phase 1, and phase 2, it's the inward calcium channel and the efflux of potassium, so which causes a balance, so it's a plateau. Then again the third phase, it is due to efflux of potassium channel, efflux of potassium. So phase 4 is resting. So it is the cell membrane. In this phase, the cell membrane is impermeable to sodium. Potassium moves out during this phase. Okay. So cardiac physiology, I have explained, like it generates from the SA node, then it goes to the AV node, then from the AV node, it travels along the bundle of his, and then it goes to the Purkinje fibers here. Okay. This is the bundle of his, this is the Purkinje fibers, and then it depolarizes the heart. Actually, the SA node, it was the last one to be discovered in 1907 by Keith and Flack. The AV node and bundle of his bundle was described first in 1893. In 1880, the Walter Gaskell described the impulse of heart that originated from the sinus venosus. That is basically the AV node. Then 1906, Suno Tawara described that impulse originating from the proximal end of the is bundle, that is AV node. He also said about the AV node. But after previously it was thought that all the waves are originating from the AV node, but still the lacking in the knowledge was fulfilled when discovery of AV node, SA node was made in 19 Hello, sir. Hello. 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 Hello, sir. Can you hear me, sir? Hello.
We can hear you now. In between, for a moment, we lost you, but now
No,
we can
ma'am,
hear.
somebody has muted me, ma'am. I don't know. Okay.
You take control. Take control. You can take control. You can mute everyone,
Yes,
but
ma'am.
no one can mute.
Okay. Okay. So now his Purkinje system I had described. So moving on to. So this is the electrical conduction of the heart. The electrical impulse starting from SO node traveling through the first depolarizes the atrium. First the right atrium, then the left atrium, then it comes to the AV node, then bundle of his, then Purkinje fibers and the ventricles. Okay. So now talking about the pacemaker potential. This is the potential which is different from is abnormal. So there is no there should not be any ST depression in the precordial leads. So whether if it's like 1 millimeter, 2 millimeter, we consider it as abnormal. Okay. So this is the ST segment like QRS. This is the lead AVF. So ST segment is from here to starting of the T. This is the ST segment. Okay. So ST segment depression it will occur in like N STEMI, so non-ST elevated elevation MI. Then if you see a ST elevation, it most probably denotes like acute MI, like ongoing MI. So this is the T wave. So T wave is like after the ST segment and before the T wave denotes the ventricular repolarization, and then ventricular repolarization. Okay, it proceeds in direction of ventricular excitation. So QRS positive, then T wave is also positive. Okay, it is upright in 1, 2 and leads V5 to V6. Inverted in AVR. So when inverted in 2 or more right precordial leads, it is referred to as persistent juvenile pattern. So it in pediatric patients, it is like inverted. So in right precordial leads, so the right precordial leads are V1, V2, V3. So it is normal in pediatrics, but when it is going to the adulthood, if you are seeing without any other significant changes, only T wave inversion, so you can diagnose it as persistent juvenile pattern. Okay, persistent juvenile T wave pattern. Okay, so then coming on to next slide. Okay, so in limb leads, it is tallest in lead 2, normally less than 6 millimeter in all limb leads. It should never be less than 0.5 millimeter. In precordial leads, it is tallest in V2, V3, smallest in left precordial leads. So this is the T wave. Okay. T wave in AVF. So tall T waves, if you see, it can be due to hyperkalemia can cause tall T wave. Then acute MI can also cause tall T wave. So here QT interval I told, like from the beginning of the Q wave and the end of the T wave, that is the QT interval. So it represents the period between ventricular systole, period of ventricular systole from isovolumetric contraction to isovolumetric relaxation. It is measured from QRS to end of the T wave. Lead with large T wave and distinct termination is used for measuring QT interval. Lead V2, V3 are usually best for this measurement. Okay. So QT interval, it varies with the heart. QT also varies with the heart rate. So it increases if heart rate decreases, and it shortens so if heart rate increases. So basically in tachycardia, the QT interval shortens. So if the patient is having bradycardia, QT interval lengthens. So in calculation of QT interval, like you have to be very careful. There is a formula and all I will be describing. Okay. It increases slightly with age, and diurnal variation also affects the QT interval. The normal QT interval is 350 to 450 milliseconds for heart rate of 60 per minute. For every 10 beat increase or decrease, 20 millisecond is deducted or added to the QT. So Besset's correction. So it is basically the corrected QT interval is calculated. This is a mostly used method. Here we divide the QT from the ECG by square root of RR interval. So the RR interval should be in seconds. Okay. Then Hodges method. Here QTC is calculated by measured QT plus 1.75 into heart rate in beats per minute minus 60. Okay. So there will be you can predict the obvious abnormality if QT is more than half of RR interval. So here you can see the QT prolongation here. So this is the QT wave. So this is like, okay. So here you can see the increased QT interval. So normal is 350 to 450 milliseconds normal. Okay. 350 to 450 milliseconds. Okay. Same here. Okay. So coming on to the next wave, U wave. So U wave is the low frequency deflection after the T wave. So here is the T wave. So this is the U wave. So basically in most of the times you will not see U wave. So sometimes you can see also, like in conditions you can see U wave also. Okay. But it can occur normally also. This U wave can occur normally also. Beat arising after each QRS wave. It is like same in appearance, and a small foci is producing this at a regular interval. Okay, in multifocal or multiform PVCs, the different appearance of, you can see the different appearance of PVCs. Here the multiform means the coupling interval will be different. In multifocal, the coupling interval will be same. Like here you can see at the same interval it will come, but different foci is producing different type of PVCs. It is most commonly seen in diseased heart. Couplet and triplet PVCs. Couplet is two types of premature ventricular ventricular beats occurring simultaneously. So here also you can see it most commonly occurs after T wave. Okay, so here T wave you can see two premature ventricular beats. Okay. This is the R on T phenomenon, where it usually occurs after the T wave. So R on T phenomenon, the significance is it can lead to ventricular tachycardia or ventricular fibrillation. So in mostly in cases of MI. In triplet, the PVCs occur in triplet. Okay. So coming to bigeminy and trigeminy. So you can see the here ventricular bigeminy. So it occurs after every normal beat. Okay. The sinus impulse is this is the sinus impulse, which is followed by the premature ventricular beat, which is produced by the foci in ventricles. Okay. Here you can see this is the trigeminy. After you can see a ventricular beat. So the premature ventricular beat. This is trigeminy. Then coming on to pericardial diseases and pulmonary disease. Like pericardial disease, the two main conditions are like pericardial effusion and pericarditis. In pericardial effusion, the fluid accumulates between the visceral and the parietal pericardium. The pericardial space contains 15 to 50 ml of fluid. In cardiac tamponade, like in aortic dissection and all, you will get more amount of blood as collecting between the pericardium, which can compromise the contraction of the heart. So basically in pericardial effusion, you can see low voltage complexes because the fluid which gets accumulated in between the pericardium, like in between the pericardium, it will obstruct the contraction of the heart. So you will see different amplitude waves of QRS complexes. This is called as electrical alternance. Then also you will see a low QRS complex with a different amplitude. So different amplitude, so we call as electrical alternance. This is significant of pericardial effusion. Then coming on to acute pericarditis. In acute pericarditis, you can see like
नेक्स्ट
ST
करो
elevation.
इसको, leave it, रहने दो उसको, आगे चले.
You can see like patients presenting with in ECG changes. You can see sinus tachycardia with right axis deviation and then changes of RBB.
ये इतना important नहीं है इनके लिए. Pulmonary embolism में ECG changes. That आगे चलिए नेक्स्ट.
Okay, ventricular tachycardia. So ventricular tachycardia is when there are 3 or more ventricular premature beats occurring. So we call as ventricular tachycardia. This is like an emergency condition, and then you have to assess and sometimes cardioversion may be needed in these patients. Okay. The point is this is basically the polymorphic VT. The polymorphic VT. It is most commonly maybe due to hyperkalemia can cause this, and the congenital syndromes are there which can cause those are its the point is, and also medications like class 1A and 3 antiarrhythmics, then ondansetron. So
Yeah.
there are various.
Just stay on the torsion D point. It is a twisting of the peaks of the RPF, and this is it may lead to the normally. So it's revert back to the normal spontaneously. Sometimes electrical cardioversion is required, or the deficiency of the magnesium sulfate or the abnormal electrolyte means electrolyte imbalance has to be corrected in this torsion D point, and it's very dangerous. It may lead to the ventricular further fibrillation and cardiac arrest. So it's very important to identify it. ठीक है. Next, चलो.
Idioventricular rhythm, when the like pacemaker is producing more than sinus node, you will get a idioventricular rhythm. Here rate will be like 20 to 40, rhythm will be regular, P wave may be absent. Okay, the QRS complex will also be more than 0.12 milliseconds. So 0.12 seconds. Ventricular fibrillation. This is like sine and fine coarse wave. You can see this is ventricular fibrillation, and this is also like according to ACLS guidelines, you have to defibrillate the patient as soon as you see these waves. Okay. Then coming on to Wolff-Parkinson-White syndrome, these are congenital syndromes. Like there will be an accessory conduction pathway where the conduction from the SA node will directly reach the left ventricle, so that left ventricle will start to contract before the impulse from the AV node and Purkinje fibers reach the ventricles. So you will get a characteristic. This is the delta wave. So this is the delta wave because the impulses coming through this is the accessory pathway. Mostly this is called bundle of Kent. Okay, so it can be present over the left atrium. So bundle of Kent, through this the impulses coming from the SA node will travel and depolarize the left ventricle before the impulse from
It is
the
a
AV node.
pre-excitation syndrome. It is called also pre-excitation syndrome, and it is because of the abnormal pathway between SA node and the AV node. Usually the impulses to come through the wall as well as the normal pathway, but in this case abnormal pathway. अब इसका जो इसीलिए इसमें just after the finishing of the P wave that R wave started pre-excitation, right? So इसका इमीडिएटली होता यह है कि इसमें लॉन्ग टर्म में तो इसको एब्लेशन करवाना पड़ता है इसमें, ठीक है ना?
You can see the PR interval will also be reduced like less than 120 milliseconds. Okay, so here you can see the delta wave characteristic. Okay, so then coming on to Brugada syndrome, this is also a congenital syndrome. Here this is a sodium channelopathy. Here there will be only ST elevation.
Not as much on the Brugada syndrome.
That's okay. Then a prolonged QT. Congenital syndromes like Jervell-Lange-Nielsen syndrome, Romanov-Watt syndrome. So this can cause prolonged QT acquired due to medications I told like antiarrhythmics, then ondansetron. So it can cause acquired QT. Then most importantly, electrolyte abnormalities, hypokalemia, hypomagnesemia, hypocalcemia. Then structural heart disease can cause acquired long QT syndrome. But sir. Both long QT and short QT both can cause fatal ventricular arrhythmias. Revision here, if you want. So this is
8 steps of
normal ECG.
8 step बताना वापस 8 step. before this, just before this, 8 steps.
We have to calculate the rate, then rhythm. Then we have to see the axis of the ECG, left axis, right axis. Then T wave, any P wave changes are there. Then coming on to the PR interval, if PR interval is normal or prolonged. This is a systematic way so that we don't miss anything while seeing ECG. Then after PR interval, you have to see the QRS complex, whether it's widened, any changes are there. Then QT interval you have to measure, you have to see and measure. Then ST segment and T wave changes. So if you do like this, we will mostly not miss any findings in the ECG. So you have to see everything in all the leads.
So
can anyone answer this, like this ECG, findings of this ECG? Answer this ECG, sir, if anyone is like. Hello. 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 Sir, hello. Hello, sir. Can you hear me, sir? Hello, sir. Hello. Hello, sir.
yes, hello. हाँ बताइए.
Anyone is interested can answer this ECG, sir. Like findings of this ECG. Almost I have completed, sir. Just,
Okay.
like
so now almost all slides are over.
yes, sir.
So these are the exercise, some ECG.
Yes,
So
sir. Exercise ECG, sir.
you can discuss about this कि कैसे आप ECG पढ़ेंगे. देखिए जरा इसमें कौन बताएगा इसको, बताओ भाई.
Hello.
हाँ बताओ.
Hello, sir.
हाँ जी.
Sir, this is biventricular hypertrophy.
बाई वेंट्रिकुलर, हाँ एक्सप्लेन करिए पूरा. एक्चुअली में जब भी कोई ईसीजी पढ़ते हैं तो आप कैसे पढ़ोगे इसको, सीधा डायग्नोसिस. डायग्नोसिस नॉट मच इम्पोर्टेंट.
Sir, the S wave is deep in V1 and V2.
Okay.
And the R wave is
एस
tall
वेव
in V5.
मैं दूसरी स्लाइड देख रहा हूँ, या तो मुझे कुछ V2 में मुझे डीप एस वेव नजर नहीं आ रही. Okay. This is normal ECG है.
Yes, sir.
Okay. हाँ इसको पढ़िए आप. इसमें क्या क्या कैसे हम बताएंगे कि ये ECG ऐसे है. अभी
In normal ECG, sir.
Normal ECG ना.
First, we have to look at the rate.
Very good.
Rate we'll calculate by calculating the number of small squares between two R waves and dividing it dividing by 1500 by the number of small squares, sir.
Okay.
Or 300 by number of large
So,
squares.
फर्स्ट हो गया रेट, उसके बाद में हो गया रिदम.
Rhythm.
How will you evaluate the rhythm?
Rhythm will be the RR interval should be same, sir.
Okay. ठीक है ना. So RR interval is the same. तो रेट हो गया, रिदम हो गया. उसके बाद में
एक्सिस देखना है सर.
एक्सिस देखना है. ठीक है. देखिए जरा एक्सिस आप.
Here the lead 2 has the positive the highest positive R wave, so it is normal axis.
नॉर्मल एक्सिस है. ओके ठीक है. तो नॉर्मल एक्सिस हो गया. और उसके बाद में क्या देखेंगे, पी आर इंटरवल है ना.
ओके सर.
मॉर्फोलॉजी देखोगे, पी वेव का मॉर्फोलॉजी देखोगे, क्यूआरएस का मॉर्फोलॉजी देखोगे, इंटरवल देखोगे. ठीक है ना. एक्चुअली में कई बार रहता है कि फर्स्ट डिग्री हार्ट ब्लॉक में नॉर्मल ईसीजी आता है. ठीक है ना, एक्सेप्ट द प्रोलॉन्गेशन ऑफ द पीआर इंटरवल।
Okay,
तो
sir.
हमें वो भी देखना है। तो पीआर सेकंड है कि आप जब आप पी वेव्स देखोगे उससे पता लगता है पी वेव कैसी है। पी वेव आइडियली किस में देखते हैं हम सबसे ज्यादा कॉमनली किस में देखते हैं? सेकंड में देखते हैं
And V1, 2 and
And-
V1, sir.
2 and V1 में देखते हैं। वेरी गुड। सो ओके, V1 में कैसी होती है पी वेव नॉर्मली?
Normally, it will be biphasic, sir. It
उन्होंने बताया भी था मेरे ख्याल से।
or negative.
एंड उसके बाद में हमें QRS कॉम्प्लेक्स देता है, इट्स ए नैरो और द ब्रॉड, ठीक है ना?
Yes, sir.
नैरो में कि 0.12 सेकंड से कम होना चाहिए, करेक्ट? अगर ज्यादा है, ठीक है, तो वो अब वाइड QRS कॉम्प्लेक्स, क्या ऐसी सिचुएशन होती है जिसमें वाइड QRS कॉम्प्लेक्स किस में आते हैं? जब कोई भी रिदम में वेंट्रिकुलर ओरिजिन हो। तो मुझे वो रीजन बताओ जो सुप्रा वेंट्रिकुलर रीजन हो और उसमें QRS कॉम्प्लेक्स वाइड हो।
Sir, sir, what is the question, sir?
Question is the tell me the cause where the QRS complex wide, but this is not originated from the ventricle. Usually जितनी भी ventricular rhythm होती है ना,
Yes,
सुन
sir.
रहे हो?
Yes,
वो
sir.
सब जो है वाइड QRS कॉम्प्लेक्स देती है। जितने भी वेंट्रिकुलर रिदम होती है, वेदर इट इज फ्रॉम द पर्किंजे फाइबर्स, वेंट्रिकुलर मास और द बंडल ब्रांच, वो सारी वाइड देती हैं, ठीक है?
Yes, sir.
जो जितने भी VPCs आए हैं, है ना, PVCs, VPCs, VPB जो भी कहते हैं, एक्स्ट्रा सिस्टोल, ठीक है ना, वो सब वाइड होती हैं। वही उनका
Yes,
ये
sir.
रीजन होता है कि यस, वेदर इट इज अ वेंट्रिकुलर टेकिकार्डिया हो गया, ठीक है ना, और जो VPCs हैं उनकी वजह से है, वो सब वाइड होंगी। ऐसी कौन
Yes,
सा
sir.
रीजन है कि वो नॉर्मल साइनस रिदम से ओरिजिनेटेड है इम्पल्स, बट इट इज गिविंग टू द वाइड QRS कॉम्प्लेक्स?
बंडल
ये
ब्रांच ब्लॉक
है ना? सो क्लियर है। तो जब भी बंडल ब्रांच ब्लॉक होता है उसमें वाइड QRS कॉम्प्लेक्स आता है और वो साइनस ओरिजिन होती है,
यस
ठीक है? फिर उसमें हमें देखना है कि कौन सी बंडल का ब्रांच ब्लॉक है, करेक्ट? ठीक है,
यस सर
चलो और भाई कर लो डिस्कस। बाकी हो गया, ऑलमोस्ट पूरे हो गए। This atrial fibrillation, show me the atrial fibrillation just now. This is okay. What is this rhythm? कैसे कहूँ इसको एट्रियल फिब्रिलेशन? कोई एक्सप्लेन करेगा मुझे? मैं इसको एट्रियल फिब्रिलेशन बोलने की कोशिश कर रहा हूँ। somebody tell me, somebody can explain it, why I'm this diagnosing atrial fibrillation, this strip? कोई बताएगा the reason behind it? Nobody. गोकीला एब्सेंट है। हाँ गोकीला बताओ, ये क्या रिदम है बेटा इसका?
सर इसमें पी वेव एब्सेंट है सर।
ओके, वो तो जंक्शनल रिदम में भी होती हैं।
और इरेगुलर
जंक्शनल रिदम में आइदर पी वेव एब्सेंट और द, कई बार जंक्शनल रिदम में ऐसा होता है कि वो एवी नोड के बाद में जनरेट होती है और उसमें मर्ज होते हैं आपके एसवे में, ठीक है ना, तो मर्ज हो जाती है, पता ही नहीं लगता है, या शुरू में होती ही नहीं है। कई बार वो QRS कॉम्प्लेक्स में ही मर्ज हो जाती है तो नजर नहीं आती है,
हाँ सर,
है ना? तो इसको
यस
मैं
सर।
तो इसको क्या कहें? हाँ, पी वेव नहीं है।
और
ओके,
इरेगुलरली रेगुलर रिथम भी है।
इरेगुलरली इरेगुलर रिदम है। वेरी गुड। सो अगर फिब्रिलेटरी वेव्स है, या तो वो नजर नहीं आ रहे हैं, या मल्टी, जो कोई कैसी है, कोई कैसी है, कोई कैसी है। फिब्रिलेशन मतलब है कि एट्रियास में अलग अलग अपने अपने हिसाब से आ रही है, एक दूसरे को न्यूट्रलाइज कर रहे हैं। इधर की इलेक्ट्रिकल फोर्स, इलेक्ट्रिकल फोर्स दोनों न्यूट्रलाइज कर जाती है, ठीक है ना? या डॉट शेप में आती है,
यस
या
सर।
नजर ही नहीं आती है, तो वो फिब्रिलेटरी वेव्स होती है। सो द डायग्नोसिस ऐसे ही करेंगे कि इसके आरआर इंटरवल हमें देखना है, ठीक है ना?
हाँ यस सर, यस सर।
Continuous. अगर वो इरेगुलर है तो मोस्ट लाइकली दिस इज द एट्रियल फिब्रिलेशन। क्या कॉमन कॉज होता है एट्रियल फिब्रिलेशन का?
Sir, mitral valve disease.
mitral heart disease, thyroid toxicosis भी होता है सर। like drugs like ADR।
एडीआर करती है एट्रियल फिब्रिलेशन, ऐसे नहीं मारो। फिब्रिलेशन वहां पे करती है जो एट्रिया कैओटिक
सर
में कांटेक्ट करना शुरू कर देता है,
बेसिकली
मोस्ट लाइकली। और जब भी एट्रियल वॉल, या तो एट्रियल वॉल बहुत ज्यादा इनलार्ज हो गई है, ठीक है ना,
हाँ
वहां से
यस
होती है।
सर।
जो माइट्रल वेल्वुलर डिजीज होती है, जैसे माइट्रल स्टेनोसिस, उसमें हो जाता है, ठीक है ना?
यस
तो
सर।
अगर
basically whenever atria will be dilated, more pressure in the volume in the atria,
क्या
so that will
इसमें
induce
इन केस, अगर जैसे इसमें एट्रियल फिब्रिलेशन यूजुअली एक क्रोनिक एट्रियल फिब्रिलेशन होता है माइट्रल स्टेनोसिस में, अगर ये क्वेश्चन ठीक है, क्लिनिकल क्वेश्चन क्या पूछे, चलो लेट इट टुडे ईजी क्लास ओनली।
Okay, sir.
हीमोडायनेमिकली इनस्टेबल हो जाता है अगर इसमें मोर जो वेव्स हैं वो एवी नोड के पास होके और ज्यादा हार्ट रेट बढ़ जाता है, तो इसको कंट्रोल करना होता है उस सिचुएशन में, क्योंकि हाइपोटेंशन हो जाता है माइट्रल स्टेनोसिस में। यूजुअली जो, अगर उसको आप अगर कार्डियक एनर्जी देते हो, जूल देते हो, तो उसमें नहीं देते हैं यूजुअली, जब तक कि वो डायग्नोस नहीं हो जाता है कि इसमें कोई थ्रोम्बस तो नहीं है। एट्रियल फिब्रिलेशन में कॉमन कॉम्प्लिकेशन ये होता है कि एट्रियल लेफ्ट एट्रियल अपेंडेज में थ्रोम्बोसिस जनरेट हो जाता है, ठीक है ना, क्योंकि वो एट्रियल किक नहीं देता है इसलिए, ठीक है, तो थ्रोम्बोसिस जनरेट हो जाता है। ओके, चलो आगे और कुछ।
So, this one anyone can describe.
मेल विद चेस्ट पेन, 47-year मेल विद द चेस्ट पेन। हाँ जी, बताइए इसमें क्या है, बताओ, कौन बताएगा?
Sir, ST elevation in lead 2, 3 and AVF.
लीड 2, 3 एंड AVF में ST एलिवेशन है। सो तो इसे प्रोबेबल डायग्नोसिस क्या निकालेंगे हम? इट इज द
inferior
Hello?
wall MI.
inferior wall
हाँ sir, inferior wall MI.
MI।
Myocardial
Okay.
infarction.
Very good. So इसमें बिल्कुल सही कहा है, इसमें तो मोस्ट प्रोबेबली ये ओके। ये देखिए, हाँ इसको देखो, इसका ये देखा है, इसमें वेव कितनी अच्छी आ रही है इसमें। लीड, ये देखिए AVL है ये, वो वापस देना डेल्टा वेव्स। दिस इज अ प्री एक्साइटेशन WPW सिंड्रोम, ठीक है ना। ये देखो इसमें डेल्टा वेव्स, इसमें क्लियर, ये देखो वाओ, लीड 1 में कितनी अच्छी आ रही है, ये पता लग रहा है इसमें, प्री एक्साइटेशन सिंड्रोम। वेरी गुड, ठीक है, पहचान लोगे इसमें, ठीक है,
Thank you, sir.
ओके। Okay, thank you all. Thank you very much. And my suggestion is just to stick with the basics. बेसिक बहुत इंपॉर्टेंट है, ऐसे याद नहीं होती है कि उसमें क्या चेंज आया, उसमें क्या आर वेव एस वेव बन रही है, किसमें डिप्रेशन हो रहा है। क्लियर कट आपको ये पता होना चाहिए कौन सी लीड कहाँ से क्या देखती है, हार्ट का कौन सा पार्ट देखती है, तब जाके हम। और जब भी आप ईसीजी देखते हो पीएससी में, उसी हिसाब से देखा करो। ऐसा नहीं है जैसे इसकी बारी है, फर्स्ट देख ली, सेकंड देख ली, थर्ड देख ली, नहीं। इसको देखो कि फर्स्ट को एवीएल के साथ में देखो, सेकंड एवीएफ, थर्ड को एक साथ में देखो, V1 V2 को एक साथ देखो, V3 V4 V5 को एक साथ में देखो, ऐसे देखो उसको, ठीक है ना। चलो, थैंक यू वेरी मच। शुड आई लीव नाउ?
Thank you.